Okay, so much like adults, we have children who suffer from mental health issues. Children are by no means little adults. They come with their own issues, they're handled differently, and very often treated differently. So disorder exists when behaviors are not age or culturally appropriate. It usually results in maladaptive functioning. The first disorder we're going to look at is an intellectual disability. Now, this is something I'm sure you hear quite often, someone having an intellectual disability. So I'm assuming it's not a new term for anyone. This is a deficit in intellectual functions such as reasoning, judgment, academics, or even learning from experience. This functioning will see a child who fails to meet standards for personal independence as well as social responsibility. They will have problems with ADLs across multiple environments. Usually starts before age 18. It can be mild, moderate, severe, or profound. And as we go through the material tonight, if anyone skimmed through, you'll realize that it is a lot of information. A lot of this is just to give you some insight into what they are, just to touch on a lot of the topics. The following slide goes over the degrees of intellectual disability, which we will not get into tonight. You can take a look at this on your own, just to explain the difference between the mild, moderate, severe, and profound, the different IQ levels, and the functions they're able to perform at that level. So what causes an intellectual disability? There is a thought that it could be a chromosomal abnormality, as well as it could be caused from a medical reason or even toxins in the environment. Has anyone worked with anyone or any close contact with anyone with an intellectual disability? I'll take that as a no. Language disorders. This is a persistent difficulty as it relates to acquiring and or using language. It's seen in written, spoken, or even in signing. This child will have a reduced vocabulary, limited sentence structure. Their social communication skills will be impaired. What is expected for age? They will not meet those guidelines. They will function well below those guidelines. And as we go through the different disorders tonight, at the very last bullet, and even as we go into psychotic disorders, we'll say not due to medical or neurological conditions or intellectual disability. That means if a child has a language disorder and they have a medical, neurological, or intellectual disability that could account for that language disorder, then it wouldn't be a language disorder, it would be termed something else. So it has to be separate from being caused by anything else. A phonologic disorder, which is speech and sound disorder. This is a persistent difficulty in producing speech sounds. This disturbance will limit effective communication, as you can imagine, and it will interfere with academic achievement. It's usually in the early developmental years. And again, it's not due to any congenital or acquired conditions. And it usually continues past age 8, because in the earlier years, it is understandable that some children will have difficulties with forming words or developing. Does someone have their microphone on? There's an echo. So usually if you have a speech sound disorder diagnosis, it usually continues past age 8. Then we have childhood onset fluency disorder. This is stuttering, which I have. I've stuttered all my life since I was a child. As I've gotten older, I think it has gotten better, but I still do stutter. This is a disturbance in fluency. and patterning of speech. Sometimes there's difficulties with sounds, syllables, or repetitions. Sometimes there are even sound prolongations where people who stutter have a hard time getting sounds out, so they will like say a while before they finally get the word out. It could be broken words. It could be audible or silent blocking, just trying to get the word out and it's just not coming out. There could also be some circumlocution. This is the use of many words where few words could be used. I am very guilty of that. Sometimes I want to say a word because I know I will stutter on that word. I will say an entire sentence when a word would have proved a lot more efficient in saying what I need to say. It often causes social anxiety, and that is why when I was again asked to do this class a year or so ago, I had a lot of reservations about doing it because I'm like, I stutter. But then I decided I'm going to face my fear head on, and then I went ahead and did it. Here I am today. Again, it's not due to any medical or neurological condition. Then we have, well, that is awesome to hear. Then you have a social communication disorder. It is persistent difficulties in social use of verbal and nonverbal communication. The child will have deficits in greeting or sharing information. There's impairment in their ability to change communication styles to fit the social context. So they will struggle in like the social setting in terms of using the correct terms or correct expressions to share their thought. This child will have difficulties in following rules or conversations and storytelling. They'll have difficulties in understanding what is explicitly stated. It'll impact their life and social relationships, and again, not caused by medical or neurological issues. It's usually apparent after age 5 or even in the early adolescent years. That's a social communication disorder. Then we have selective mutism. This is one that I'm very fond of. This is a child will have a consistent failure to speak in social situations where one is expected to speak. I mean, when are you not expected to speak? You're expected to speak at home, at school, wherever you go. As long as you've developed language, you're expected to speak. But this child will fail to speak in some situations, or sometimes all situations. And they will choose to speak in other situations. It impacts and interferes with academic, occupational, and social functioning. It's important to note that this failure to speak is not related to a lack of knowledge with the language or comfort with the language. I worked as a school nurse for 10 years, and there was one little boy who started with us in pre-K. Pre-K, K, first, and second. I left in his second year, his second grade year. And since the little boy entered in first grade, he has never uttered a word at school. By the time he got to in pre-K, it was like, oh, he's little, he's shy, and nobody paid much attention to it. But then he got to kindergarten, and he still wouldn't say a word. And so after school was concerned, we reached out to his pediatrician, and the pediatrician wrote us a letter saying, little Johnny speaks very eloquently when he's in my office. He points at posters, he asks questions, he runs around the room screaming with his sibling. Everybody had like their mouth wide open. And for those 4 years I was there and he was there, he never said a word. The father would show us videos of him running and screaming and yelling at home, but he had that self-control where at school, never uttered a word. Well, there was this one time when he was using the computer headphones on, and I guess he was lost in whatever he was doing on the computer, and he laughed out loud. And when he did, he grabbed his mouth and looked around. Of course, when he looked around, everybody else was looking at him like, your voice. It never happened again. I'd be curious to know if he ever started talking at school. I know. So of course, it's difficult for the teacher to assess him or speak truly to his abilities because he doesn't engage in the classroom. So that is selective mutism. Now there's Rett's disorder. It's relatively uncommon. It affects males and females, but males are usually not viable at birth. Usually presents before the first birthday, beginning age 5 and 30 months, around there. This child will still gain developmental milestones. And if they had gained those milestones, sometimes, well, very often they lose those skills they had previously developed. Children with a Rett disorder have stereotypical hand-wringing movements. They have poor social engagement and poor coordination. I have never personally encountered anyone with a Rett disorder. Has anyone in this group? No? So, like it says, pretty uncommon. Someone in the group yesterday had worked with someone who had it, so I was just curious to see. They have severely impaired expressive or receptive language, often scoliosis, decreased eye contact, and their life expectancy is in their 40s. Autism spectrum disorder. This is a persistent deficit in social communication and interactions across multiple contexts. And autism disorder is something we're a lot more familiar with. It's a lot more common than Tourette's. This child will have deficits in social or emotional reciprocity, so they will not give and receive social or emotional stuff like a normal child would. They have deficits in nonverbal communication. They have deficits in developing and understanding and maintaining relationships. So this is a child who usually has a lot of social issues like engaging socially, making friends. They have a restrictive or repetitive pattern of behaviors, interests, or activities. So they're very stuck on sameness, wanting the same thing. They're very inflexible. I have a girlfriend who has a son who's autistic. He's now 4, and he eats the same thing every day. He has to be organized the same way on his plate. You can't mix his stuff. When he was like 2 years old, he was phenomenal in organizing his building blocks. He would separate them by shape. He would separate them by color. He would line them up, build very intricate designs. But his language, his speech was not developed. He's not potty trained. Well, he was potty trained, and then he regressed. He's no longer potty trained. And it takes a toll on not just the child, but the caregiver, because you're expecting little Johnny to develop into a normal child when you realize that he has this disorder. This child can be hyper or hyporeactive to the stimuli in the environment. There can be 3 levels of severity, and these signs and symptoms usually develop prior to age 3, and that's why when we speak about the levels of severity here, sometimes they'll describe saying someone is on the autism spectrum, because some autistic people are very high functioning, very smart. I have a patient right now, he's autistic, just started college, studying physics, smart, smart, smart. But his social skills, his eye contact when he's talking to me, it's totally off, but he does well academically. Then we have ADHD, which is, I think, most common of all, which a lot of kids have it, surprisingly, and a lot of young adults who don't have it want to have it. This is a persistent pattern of inattention or hyperactivity and impulsivity, more severe than the typical age and level of development. So, some kids can be rambunctious, running around, just not following directions, can't focus, won't sit still. So this is more than just the ordinary run-of-the-mill inability to sit still, focus, and or concentrate. The child with ADHD, the symptoms usually develop before age 7 and can last as late as age 12. So usually before age 7 up to age 12 is when a child is usually diagnosed. So with my patients, when someone who's in college, 19, 20, comes to me and say, hey, Zoe, I'm having trouble focusing and concentrating. And when I look up the symptoms, this is what my patient told me last week. When I look up the symptoms of ADHD, I think I might have ADHD. Of course, I know where this is going because I hear the story all too often. But I listen. And at that age, usually after age 12, some providers will have the patient fill out a self-reporting scale. But how easy is it for someone to fill out a self-reporting scale should point to the symptoms of ADHD. Very easy. What are the drugs? Does anyone know the drugs that are used to treat ADHD? It's Ritalin. That's one of them. What's the class, these drugs?
Adderall.
Adderall is another one of them. Does anyone know the class? They're stimulants. And if anyone knows, stimulants are drugs of addiction. People can get addicted to these drugs, and they have a high stress value. So when adults, new onset ADHD, come to me, I don't have them fill out a self-reporting scale. I send them for a neuropsych eval, so they have to go through a battery of tests, and then should they come back with an ADHD diagnosis, I'll be happy to prescribe for it, but not without. So these symptoms, it's pretty important to know that these symptoms interfere with function in at least two different settings. Sometimes I'll have children. If it's a child, like where I work, we use the Vanderbilt scale. It's a questionnaire that the parent fills out and that the teacher fills out. And then you take both, you compare, you go, there's a scale you go through, and then does it amount to ADHD? Does it amount to anxiety? It can tell you a lot of different things about the child. So sometimes parents will come to me with their kids and they're saying, oh, little Johnny's off the wall. He's not sitting down when he gets his homework. He won't pay attention. He does this, he this. And it sounds like ADHD. It's a classic case of ADHD. So I'll hand out the Vanderbilt till I say, Mom or Dad, you guys fill this out and send one off to the school, have the teacher fill it out. Then I get the one back from the teacher, and this child is a model student, focuses, concentrates, does well at school, teacher has no concerns. Then it's not ADHD. This is something else. Is it poor parenting? Is this a dysfunctional household? Is this just a behavioral issue with the parenting, with the dynamics with the child? So that is how we kind of tease out what is and what isn't ADHD. A child with ADHD, the symptoms significantly impair with their academics, their social and occupational functioning. Sometimes the children in school, you'll find that they have a IEP 504 for ADHD because they need those special accommodations. Sometimes if it is that they are so restless that they won't sit still, they will even have a one-to-one paraprofessional, someone to work with them throughout the day to help to keep them on task. There's a high incidence of ADHD in families with pre-existing diagnosis. So if you have it, you have a child, there's a likelihood. If your spouse has it, you have a child, there's a likelihood. If you have one child with it and you have another child, then there's a likelihood as well. So there are different theories as to the cause of ADHD. It says it could be from maternal smoking, from lead exposure, from dysfunctional parenting or dysfunctional environments. Or it could be problems with selected attention. The child doesn't like school and just has a hard time doing what they need to do. It could just be this child is impulsive, they'll be fidgety, have difficulties with social relationships, and a very low frustration tolerance. So I alluded to the drugs that treat ADHD, which is our next slide. The class of drugs are CNS stimulants. Ritalin, Defiant, Adderall, methylphenidate, Concerta, and there's a long list of them. We also have non-stimulants. So sometimes you'll have patients, well, most of the parents that come to me and they are very skeptic about ADHD drugs because of potential for abuse if it's a teenager, or they're worried that their little Johnny will not be able to function without it in the future, or they don't want their child addicted to it, so they don't want to start stimulants. And in that case, they will do non-stimulants. And that is your Strattera, guanfacine, the 10X. And it works just as well, but it is usually not the drug of choice for adults. Sometimes a child can have like a specific learning disorder. They can have like dyslexia or dyscalculia. Dyslexia is difficulties with word accuracy or fluency. They can have dyscalculia, as the name implies, difficulties with number sense, memorization of arithmetic facts, problems having accurate or fluent calculations, or accurate math reasoning. Or it could be in writing or spelling accuracy. So for a child to be diagnosed with a specific learning disorder, it must persist over a 6-month period despite having treatment. So they would have had interventions, and even with the interventions, they're still having these difficulties. And next slide that speaks about specific learning disorders and the American Disability Association. I described some of those accommodations when I mentioned Level 4s or IEPs or extra time for tests or one-to-one person to work with. So those are just some of the accommodations that you will see in a child who has some of those disorders. Then we have the developmental coordination disorder. This is a child who has difficulties acquiring and executing motor skills, or it is substantially below what is expected for their age. Say by age 6, a child should be walking well, they should be able to walk on a straight line. So it's usually not diagnosed before age 5 because 5 and under, kids can still be a little klutzy. So over age 5, this is when you'll see this diagnosis come into place. Symptoms usually interfere with your ADLs, school, socially, or in the community. It involves motor skills, and again, it's not due to medical, neurological, or any disability disorder. Stereotypical movement disorder. This is a repetitive, seemingly driven, or apparently purposeless motor behavior. Sometimes I see this in my adult patients. I don't have any child patients that are special needs, but I have a few adult patients who have intellectual disabilities and they have stereotypical movement disorders where there's like handshaking or waving. They're just like repeatedly doing that, or the body rocking, biting oneself, hitting their head, and it just goes on and on repetitively. So this is a stereotypical movement disorder. It's going to interfere with their social, academic, or any other activities. May result in self-injury. That hitting, that biting usually begins early by age 3, and again, not associated with any other thing. Are we doing good so far? Okay, someone's out there. Then we have a tic disorder. Tics are brief and purposeful movements or vocalization. So it could be a movement or vocalization. So it could be movements of the shoulders, neck, face, eye blinking, smiling, whatever the movement is, or it could be vocalization. So whatever that child is doing repeatedly, it becomes a tic. The vocalizations could also be palilalia, echolalia, or coprolalia. Palilalia is when they repeat their own words, like my name is, my name is, my name is Zoe. It could be echolalia. It could be echolalia, echolalia. So repeating words or phrases. Or it could be coprolalia. Shit. Damn. So just echoing of socially unacceptable words. Then we have Tourette's. This presents with both motor and vocal. So remember, a tic is motor or vocal, and Tourette's is motor and vocal tics. This type of tic is seen in children. They have different types of tics seen in children with Tourette's disorder. It could be simple, it could be complex, or it could be a vocal or phonic tic. Simple tics can be short, can be motor or vocal, can be clonic, dystonic, such as Tonic as in jerky dystonic, could be slow, can be long lasting. A complex tic has different or similar tics, and they're more complicated coordinated movements. They also have corpopraxia, obscene gestures, and corpographia, obscene writing. I wish I knew these things when I was little, because there's a name for that. If you're drawing obscene stuff or saying obscene stuff as a child, you can get labeled. There's vocal and phonetic tics, which I mentioned can be oropharyngeal, nasopharyngeal, so it could be sounds on the mouth, it could be nose like sniffing, barking, syllables, repeating consonants, or nonsense words. The corpulalia, palalia, and the echolalia also that I mentioned prior. So that's one group of disorders. Now we're going to look at disruptive impulse control and conduct disorders. This is where I live. Most of the kids I see have most of these disorders. Oppositional defiant disorder. This child will be angry, argumentative, defiant. And it's not just the run-of-the-mill, little Johnny doesn't listen. No, this is little Johnny doesn't listen. There's a pattern of angry and irritable moods, argumentative, defiant behaviors, or vindictiveness lasting at least 6 months. So this is a pattern of behavior that presents, and it's unrelenting, driving mom and dad crazy, driving the teachers crazy, and it goes on for at least 6 months prior to being diagnosed. So if it was only a couple weeks and he was still driving you crazy, still wouldn't meet criteria. The symptoms: this child will often lose their temper. They're easily annoyed, or often angry and resentful. They often argue with authority figure adults. They often defy authority or choose not to comply with rules. They often deliberately annoy others, often blaming others for their own behavior. They're spiteful, vindictive. They'll run away. They don't like change. Again, at least once weekly for 6 months. It causes significant distress to both them and others. Just imagine living or working with a child who has an oppositional defiant disorder. Yes, and it goes into adulthood, unfortunately. Then we have a disruptive mood dysregulation disorder, DMDD. This is a severe recurrent temper outburst, verbal or behavioral. It is also grossly out of proportion in intensity or duration to the situation. So this is not just a child throwing a temper tantrum. This is you saying, "Little Johnny, can you please put the orange juice back in the fridge?" And he smacks it off the counter, slams the fridge door, punches the cabinet. And you're like, whoa, what is going on here? These temper outbursts are grossly inconsistent with their developmental level. Like, Johnny, you are 17. Like, are you kidding me? It occurs on average 3 or more times a week, lasting over a year, occurs in at least 2 or 3 settings. This is not just little Johnny at home with you. This is little Johnny at school. This is little Johnny at football practice. He's just having a hard time regulating his mood. Between having these outbursts, he's just irritable and angry. So little Johnny is just not a nice person to be around. Usually starts before age 10. There are high rates in males before the high school years. And I do see a lot of this disruptive mood dysregulation disorder. When I was growing up, there was a cure for that. Then we have the intermittent explosive disorder. I have a few adults with this too. This is a recurring behavioral outburst presenting a failure to control aggressive impulses. As the name states, explosive. They have verbal aggression, temper tantrum, triads, aggression to others, or damage property. The triads is referring to this child like pitting people against each other. Oh, mom told me, dad, you said mom couldn't, and mom said dad said I couldn't, so forming triangles in their relationships, triads. The aggression is grossly out of proportion to the situation, usually from minor provocation. Are not premeditated and are not related to intimidating. So this child not necessarily a bully, they just have a hard time controlling their impulses. Usually at least age 6. Then we have conduct disorder. This is a persistent pattern of behaviors in which the basic rights of others or society are violated. There are behaviors in 4 major areas for this child. They will have aggression to people or animals. They will have destruction of property, deceitfulness, theft, and there will be a serious violation of rules. So as this child becomes an adult, these behaviors necessarily go away. Sometimes the child could learn to curb those impulses and become a better person. But if these behaviors continue into adulthood, this child will be labeled as having an antisocial personality disorder. That's something important to know. They'll be labeled as having an antisocial personality disorder. And where do you think you'd find someone with an antisocial personality disorder in the public? Prison, exactly. If you are aggressive, destroy property, you're deceitful, you violate rules, then you're breaking the law. But as a child, I guess, you find them in juvenile detention too. This will cause a significant impairment in social, academic, and/or occupational functioning. There's usually a lack of empathy, a lack of remorse, a shallow affect, and they seem totally unconcerned. So I killed the cat. And? Oh, that was your money that I took? Oh, it was for the rent? Oh, my bad. So how do we treat these disorders? I mentioned stimulants, the Adderall, the Dexedrine, the Ritalin. Yes, they do have those psychopathic tendencies. You can see exactly where they're headed. The Dexedrine, the Ritalin, the methylphenidate. So these are the that are prescribed for kids with ADHD. I do not prescribe, or by law, I cannot prescribe any more than 30 days at once. That's because there are drugs of abuse. You don't want to give anybody a large amount, because sometimes I'll have patients who get lost and come back for a refill, and very often the insurance will give you a lot of pushback if you try to refill before the 30 days, because these drugs have a high street value and people have figured that out. Long-term use, as I mentioned, may be addictive. They should be taken 30 to 45 minutes before meals. Does anybody know why they should be taken before meals? This is because they suppress appetite. No, they suppress appetite. A lot of kids who take ADHD meds, very often parents will do holidays like on the weekends or for the entire summer even. Because very often these kids are most times underweight, they're younger than their stated age because of the stimulant use. So sometimes they'll take drug holidays so their kids can catch up. They suppress their appetite. Or very often you'll find these kids like I will collaborate with like the pediatrician and they'll prescribe like Pediasure or meal supplements because it fills them up. Like once you take the pill, no appetite. It's listed here that they should be avoided when someone has tics or Tourettes or glaucoma or seizures because it is said to worsen those symptoms. It also mentions to avoid caffeine with stimulants. Why? Why do you think you should avoid stimulants? Well, if you're taking stimulants, avoid caffeine.
Would it increase the effect?
Yes, because coffee is in itself a stimulant. And that is why when I do my assessments and I ask, are you using any drugs? Drinking any alcohol? No, no. Any nicotine? No. Coffee? They're like, coffee? Coffee. I'm like, yes, coffee is a stimulant because if you're going to tell me you're anxious, you can't sit still, and you're also telling me you're drinking 6 to 10 cups of coffee a day, then that's your problem right there. We also have antidepressants. Antidepressants are used to treat some of those mood disorders like the DMDD, dysregulation disorder. And those are usually the first class that we use for SSRIs, are the first class of drugs that we use are SSRIs, and that's your Prozac. 1 second, guys. And that's your Prozac, your Paxil, your Lexapro, your Celexa. And the SSRIs are usually the first class of drugs used because they have a low side effect profile. Do you see children using these drugs? Very regularly. There is a black box warning, which means we have to tell parents when we prescribe these drugs for their adolescents that there's an increased risk of suicidal ideations when they take these drugs. And very often parents are like, what? Then why would you even want to prescribe this drug? And then I have to add, that's because research has shown that they're more helpful than they are harmful. And usually if a child develops suicidal ideation from taking SSRIs, it's because there is some underlying disorder. There's something else going on. This is not just not the run of the mill, what we think it is. And very often it's like a bipolar disorder or something else underlying why they have this. It's called an activation syndrome from an SSRI drug. The advantages of the SSRI use is that they treat many disorders. Of course, they also have disadvantages. It could cause weight gain. When adults take these drugs, this is like some of the most common drugs you will see because they treat mostly anxiety and depression, which are very, 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 very common. Almost 8 out of 10 patients have an anxiety or depressive disorder, which means they're taking antidepressant, which is not just antidepressant, it's an anxiety too. Most of them treat anxiety and depression. So these side effects are for adults too. There could be weight gain, decreased libido. It may cause a neuroleptic malignant syndrome if used with MAOIs. That's another class of drugs. And it may cause a serotonin syndrome if used with migraine meds. I remember I had one patient who, actually not one, I've had more than one patient who they will have the drug, they'll take the drug and it's working and it's treating their anxiety, treating their depression. And probably like by the second follow-up, they're like, there's something that I've noticed, Zoe. And it's usually the guys that are a little bit hesitant to discuss it, but they're like, I'm not getting up like I used to, or I'm just not interested. My girl thinks I'm cheating. And I'm like, it's the drug. They're like, yes. I'm like, it causes a decreased libido. And some patients say, oh, leave me on. It's working for my anxiety and depression. I was like, no, we need to change the drug because we don't change it. Then you're going to have other stressors in your life. You're going to have other problems from decreased libido. So let's try to take it across the board. So very often we change it and everybody's happy. So I mentioned that SSRIs can cause a neuroleptic malignant syndrome. This is, your patient is taking an SSRI, you walk into your patient's room. The patient is laying there with decreased consciousness, even stupor. They're stiff, have a fever. You have your stethoscope, they have a high blood pressure. It could even be tachycardic or sweating. Well, the others you would know until you run some labs. This is a neuroleptic malignant syndrome. My mnemonic for this is hot, stiff, and out of it. Hot for the fever, stiff, the rigidity, the muscle tone, and out of it, the stupor or the decreased level of consciousness. So hot, stiff, and out of it for neuroleptic malignant syndrome. That is a very important side effect to know. I mentioned you can also have a serotonin syndrome as well. And this is a patient who is confused can be somewhat hypomanic. This is a patient who is not like having full-blown mania where they need to be hospitalized, but they could be presenting with rapid speech, decreased sleep, distractibility. So those hypomanic symptoms, the restless, sweating, shivering, tremors, or diarrhea. So those are some symptoms that you can get from, some side effects that you can get from SSRI drug use. Another class of drug is the MAOIs, and unlike the SSRIs, they're the second line. So a patient wouldn't come to me in the first drug I prescribe MAOI because it's not the first line. I'd go with the SSRIs, then I'll go with the MAO if I've tried 3, 4 SSRIs and they don't work. So maybe 3 else. These MAOIs are Nardil, the Parnate, the Marplan. You must taper these dosages or you will have withdrawal symptoms. Oh no, it says connection is poor. I'm not sure what happened. Can you guys still see me? Did that just start? Can you hear me better now? Okay. Okay, great. If it continues, please let me know and I'll try to change my location. Okay. So I mentioned the MAOI as being the second line treatment for depression. It is important if you notice a patient is taking Nardil, Parnate, or Marplan, and this is why we're exposing you to these drugs so you have some insight into them. You must educate your patients that they can't just stop taking it. Well, they shouldn't just stop taking any drug unless it's something they're doing PRN, because MAOIs will cause withdrawal symptoms. MAOIs are usually first line drug use. Also, there are dietary restrictions with these drugs. See a serious increase in hypertensive crisis. No! Is it really bad where I should stop, you mean?
I mean, you keep freezing, and then like every other word you can hear, and then some of the words you can hear are like zzz, while you're talking.
Oh, wow. Robotic? Okay, I'm going to change my location. Give me a few minutes, okay?